computer. So this reading is being recorded. We're officially starting our Death Overdraft Happy Hour 10th? 11th? I did that last week.
I can't
I think
remember.
It's 11th.
Add one for good luck.
Okay. So welcome everybody. Welcome newbies. Welcome regulars to this. One of the ways we start this is we have you guys all on mute, and our chat moderator, not Matt Charterator, chat moderator is Megan, and she's already put in, because we usually communicate during chat on these happy hours. There is some time for discussion, but if you can add your name, where you located physically, what beverage you are enjoying for this happy hour, and name a state or jurisdiction where medical aid in dying is authorized. So we always have one bonus question for you. Hint, there are 10 jurisdictions, so that kind of gives you a sense of what our theme is going to be today, is on medical aid in dying. So go ahead and add that information in the chat box, and Megan later on will kind of review who you are, what you're drinking, and kind of a little bit about what you know about medical aid in dying. I'm going to stop right now and kind of do a cheers to all of you if you want to join me. Thank you. Wow. So my name's Stephanie Elkins, and I'm a continuum of care coach and consultant with Be Present Care. And my focus is really to guide and engage in caregiving and end-of-life conversations, plans, and programs with individuals and organizations. And I like to do that both in informal environments and in formal. Death Overdraft Happy Hour, I think, kind of be informal, but informative. Informal and informative. And it originally started as part of Reimagine 2019 in San Francisco, where many of you might have come familiar with us as we're part of Reimagine right now. And Jill and I, Death Doula LA and I, kind of really combined our passions of drinking beer and holding space. And so we did it at Reimagine last November. And since then, we were starting to hold Death Overdraft Happy Hours in greater Los Angeles breweries, checking out different ones. When COVID-19 happened, that kind of was on pause for a little bit, and it really just became an opportunity for us to get together on, online, doing the Zoom thing, and really, participating in this space. And with that, as I was telling some people earlier, is really the Death Overdraft Happy Hour being an incubator for the deeper dive into death team. And that's Megan and Jill and Rocio that are here right now, as well as Amber that's not joining us. So we have a diveintodeath.com site where we put all the additional information about what we've talked about here, because there's so much content we love to share. I'm the queen of just, I'm a paper pusher, but we all kind of consume so much information. So we have a place where it lives on our site. We also have a YouTube channel, which any of these previous videos you can watch, and so on. So there's a lot of way to kind of stay connected with us individually and as a group. Okay. In addition to that, we're also really pleased at this time to be part of an array of amazing free and not free programs that are part of Reimagine, Life, Loss, and Love Festival. And so we're just so pleased to be able to be part of that. And with that, I'd love to ask Rocio to read the intention that they have.
Yeah. So the intention is, there's no life without death, no love without loss. They are in constant complementary motion, but never before in our lives has the world stood so still in the face of distance, illness, and isolation. We are here together, reimagining a changed world, kinder, slower, more just. We're reimagining the giving and receiving of love, the cycles of loss and new beginnings, and what it means to be fully alive. We are here.
So before we go into our theme with, thank you, Rocio. Before we go into our theme on medical aid in dying, I also just want to do some grounding works and how the happy hour today is going to work. Once again, you're able to participate as little or as much as you want.
Get down.
Oh, I'm like, you were talking to me, right? So you can participate as much or little as you want on video or not. It's up to you. We are recording this call right now. Megan is going to be our chat moderator. Our topic is going to be medical aid in dying. If you're not comfortable at any time on this call, if it's triggering, if you're not comfortable, if something comes up, please feel free to contact Megan or any of us privately, or if you're not comfortable on the call, jump off and call us later and touch base with us. This is not a bereavement or support group, but we want to be a supportive space for conversation. So just check in with us on that. I think that's all right now on that.
Don't forget.
Oh, yes, Megan.
Mute or no video, chat or no chat, whatever you want to do, in or out. I guess you kind of said that.
Yeah, but it's okay to hear.
You said it in a new way. I liked the new way you said it. I liked it.
Okay.
Steph.
Thank you.
Also, we have to say that we are going to be using words today because we're talking about medical aid in dying. We will be using the word suicide. We will be using the word euthanasia. If those are triggering for you, take a step back. And we can have a talk later. We are going to define those words for you, and we're going to walk you through this process.
Yeah, thank you. So I'm going to go ahead and hand it over to Megan right now to kind of say who's with us tonight, Megan, and what do they know about jurisdictions that have medical aid in dying?
Well, I will say that we've got a great group, a lot of familiar faces. Their knowledge of medical aid in dying is better than mine. So cheers, everybody. As a team, we totally win 1 versus 100 or one of those game shows or whatever. And so, yeah, we've got folks from, again, all over the place and some new and some old faces. So hi.
Great. And I want to know.
Do as good as Amber does. Amber's gotten really good at that.
Let me see here. Yeah, let's see here. So one of the things I'm going to, let's see here. All right. So, how many jurisdictions have medical aid in dying right now? Was there any, so there's actually 10 jurisdictions. And they are, I'm going to read it to you. You can put this in the chat box too, Megan. Is California, it's not in this order, but this is as of 2019. This is an alpha order.
Why don't you do them in chronological order?
Okay. Yeah, let's go ahead and do that. So in 1997, it was Oregon. 2008 was Washington, Montana, 2009, Vermont, 2013, California, 2015, Colorado, 2016, Washington, D.C., 2017, Hawaii, 2018, and New Jersey and Maine in 2019. Wow. 2015 to 2019, 1, 2, 3, 4, 5, 6.
Yeah.
Six locations. And one of the reasons why we're doing this talk on medical aid in dying right now is because the California End of Life Option Act has been in existence since 2016 when it was enacted. So as of June 8th. So it's been 4 years, 2016.
Yep.
And so one of the reasons why this is such a special topic, not special, I guess it is a special topic, at least for me, is because I was working for Compassionate Choices and I was part of the California End of Life Option Act team at the time. That's when I first met Betsy. Yeah. We had a really frank conversation then. I just remember that. Yeah. At like a yogurt shop. And it was supposed to be a 5-year campaign and it passed in a year. And so it was a really an honor to be involved in political work, which I'm not really a political person on that. and going through the campaign, honoring the 4-year. And so how we're going to do this today is we're going to first kind of define what the law is, talk about the eligibility and some of the process of it all, kind of talk about language of it, and then really go into personal experiences and stories. Because we have, Megan and Jill have had experiences. I know individuals, some of you might too, and we want to give you all the opportunity to share and learn and ask your questions of us. So sharing stories, I think, is really important. Okay, so let's go right in. If you want to go ahead and put the chat question in there, the chat question 1. Let me see if I'm there. Okay, so the first question is, what is not an eligibility requirement of medical aid in dying? A, be 18 years of age. And once again, this is in the chat box. B, terminally ill. C, be on hospice. Or D, be mentally capable of making an informed healthcare decision. Which one is not an eligibility requirement? So go ahead and answer some of those. And I guess you can go, I don't know, that could be D. I didn't offer you one. You can. What is not an eligibility requirement?
And you can type your own answer. I won't kick you out for putting something, putting an E. All right, so we got some A's, we got some C's. I'll tell you what, that stumped me at first. That stumped me. I think we got mostly C's. Be on hospice. Is that right? You do not have to be on hospice?
Yeah, that's correct. So some of the eligibility requirements to qualify, and then sometimes it's to qualify for medical aid in dying under most laws, state laws, mostly we're going to work off of California, is an individual must be an adult, so 18 years of age, terminally ill, with a prognosis of 6 months or less to live, and be mentally capable of making their own healthcare decisions. So those are the standard eligibility requirements across the board. In addition to that, an individual must be a resident of the state, and that can look different how to get to be eligible for the state, the time, or what you need, the requirements of that. It needs to be voluntary. You need to be able to make an informed decision, which includes knowing all your end of life options. This is usually what's written into these laws. Informed that they may choose to obtain the aid in dying medication but not take it. So there's always an option, right? So a lot of states, it's called the End of Life Option Act, and so on. And capable of self-administering the medication. And self-administering is very different than actually preparing the medication. You have to be able to orally take it or be able to push it into a feeding tube. So those are the basic eligibility requirements across the board. Now,
so it's tricky because 2 of them, is that where you were going next?
Oh yeah, so this is just the eligibility requirement. So just to know the basis of that.
There's already huge gray areas in this eligibility requirement.
Right, and just for doctors and medical professionals to know, because sometimes prognosis is so some of it with the information with that you might say, well, how do you define a prognosis? That can be tricky for some doctors or not. There's some studies out there that say that if your doctor really likes you, they're going to give you a longer prognosis than not. There's studies to show that. The reason why the hospice is kind of interesting, hospice is really an important and value-added support system when somebody is on medical aid and who's interested in taking medical aid and dying, but it's not a requirement. But it is a valued support system that we highly recommend. Okay, so that is just what you need to know. Meanwhile, the process you have to go through to get the medication is another story. In most states, so you need 2 doctors to agree on all your eligibility requirements. And if you also know about the mentally capable of making their own healthcare decisions, that means somebody with dementia, this is always the first question that comes up, is you don't qualify. Because if you can't make a mentally informed healthcare decision at this moment in time, you're not eligible.
even if you fill out a dementia addendum directive, I think there's a lot of advocacy work to be done in this area because, you know,
Yeah, I mean, you
yeah,
talk to family. Yeah, when we talk to seniors about this, and the first thing they want to know is because they've been caregivers for family members with dementia, if it's a parent or a sibling or a partner, and they're like, we don't want to get to that state. And we have to say to them, if you have dementia and you can't make this decision right now, then you're not eligible. And that's when we talk about all end of life options like voluntary stopping and eating and drinking, which I want to pause on that because I want to make sure you guys get an understanding of what the real process is like. So 2 doctors have to agree on that. You have to identify, or they identify themselves, because there's not a list about it right now, even though there's professionals like us that know some doctors. 2 oral and 1 written request. You need to have 2 witnesses to agree that you can make this informed healthcare decision on your own. There is usually a 15-day waiting period between your first and second request. So most people think, oh, you ask for it and you can get it. You don't. It can be up to a 4 to 6 week process to even identify a doctor or to start even having these conversations, because they can be so hard. In Oregon, they have just now changed the law after I don't know how many years, right? We had identified that it was 1997, right? Is now just changed the law that it's being changed to 48 hours. Because what was happening is people were in the process and dying in the process because it was such that 15-day waiting period was too long. So all
yeah,
these
like almost half the people that I work with doing this, like we have to stop and have the conversation about timing, because it's very likely that they probably didn't think about this in enough time and that they're going to die in the 2-week period. So again, explaining all end of life options, including, you know, palliative sedation, V said, things that you can do other than medical aid in dying. I've even worked with a hospice that's prescribed, you know, phenobarbital with the other hospice medications, which together would create a potentially lethal medication. So they could use that. So there's ways kind of to work it around, but the key is timing and finding doctors that will work with you.
Yeah.
And there are deserts here in California where we can't get doctors to work with us.
Yeah.
And so we have to pay the ones who can travel, and it gets really expensive.
Yeah. So we have had it here for 4 years. So Jill's had experience, Megan had experience, a lot of stories about what the process over the 4 years. And now there's people just starting it now. I mean, that was part of my role when we were learning as we were going in terms of implementation with compassion and choices and access. After the law goes into effect, it turns into like, okay, let's make sure people are informed and have access. And there's a lot of different challenges to that in terms of doctors, in terms of access to medication. There are certain healthcare systems that were better prepared, and we were talking about from the California experience, than others. And we can talk a little bit more about that as well. Is that like Kaiser kind of has a gold standard of putting together a process when people ask. Is there still challenges within there? Sure. But overall, they've been putting together very diligent teams to make sure people there's a internal process in hand.
There is actually one that I'm deeply connected to. Mark Blyton, he's the regional head of ethics down there, and he was one of my advisors in graduate school. So, and I know he has had a lot of say in like how this is developed and used, and it feels really good to trust the ethics behind Kaiser and the way that they do their program. I don't always agree with Kaiser. It's a system, whatever, but they actually do make this really easy, which is like everything when it comes to medical aid in dying. Although they do elongate the process, it takes them about a month to get through.
Yeah. So with all this being said, it is a process. I just want to give you some other kind of data points on this so you can get a sense of numbers. Right now, across all the states that have it, there are, I'm trying to find it here. did I get rid of it? Oh, as of September 2019, 70 million people in the United States live in this state where aid in dying laws are in effect, but that doesn't mean they have access, information, and education. This is a state-by-state law, but in 1997, the U.S. Supreme Court ruled that state criminalization of MAID does not violate constitutional, I can't even say it, due process or equal protection rights.
So it was like decriminalized, essentially, is what that we're like on that road with this.
Yeah. So I also want to say that overall, among all states, of the 20 years, 3,521 people have taken a prescription to end their suffering, that have actually used this. It's not a large number, but it's, once again, having this option increases the conversation and palliative effect around end of life. Okay, so that's one. The vast majority of terminally ill people who use medical aid in dying, more than 85% received hospice services at their time of death. Terminal cancer accounts for the vast majority of qualifying diagnoses, with neurodegenerative diseases such as ALS or Huntington disease following the second leading diagnosis. Most states that have this law, their Department of Public Health creates a report. Vermont, it's not necessary for them to have it, but it's an annual report. California's comes out in July of every year from the previous year.
Yeah, numbers are looking good, and by looking good, I like that people have access to that law. Also, they're diversifying quickly as well, so that means we're getting access to people who didn't have immediate access from the start.
Yeah.
Or more difficult access.
So I'm going to pause there, and we're going to go on to the next chat question, and then we can always fill in whatever information that you need.
And all of it will be on the website.
Oh yeah,
I'm responsible for it. I'm the lagger. Give me 24 hours.
Oh, I haven't even
perfect just as you are.
Yes, you're perfect just as you are.
I just want to say one thing about shit. I had something that was really important. Okay.
Age does not qualify you for this disease. I mean, for this process.
Yes, it does.
Disqualifies you if you're under 18, but
no,
it doesn't.
age.
There's no max.
Age, like somebody's like a certain age, like if they say they're 102 years old and I'm ready to die, does not qualify you.
Maximum age.
If it's all about the doctors. It's about the doctor's assessment of a terminal diagnosis.
Yeah, I didn't say I said age does not qualify you. Like 102, if you're ready to die, does not qualify you. That's written into the California law.
But you could probably talk a doctor into saying that you're terminal because you're 102.
I'll get you a doctor.
And
yeah,
I think
you can get a doctor.
And I think that is when you have the conversation, because it's all about the conversation of why you want this, how you want the timing. So yes, it's all about your relationship with your doctors. One of the other things,
I found it. It's about how hard you advocate, because this is the wild, wild west. You will come across doctors and hospice professionals that don't even know this is legal in their state. So offering these resources, education, and then you have to fight your way through it. Unless you work with someone who has it systemized, like Kaiser, or your potential like unicorn hospice that's out there.
So one of the things before we get on to the next advocate, but also one of the things that I found very interesting and surprising that I came across when I was really, the reason why I worked for Compassionate Choices is because I wanted everybody to have the conversation about what was important to them and what they want or didn't want in their life. Some people don't even know they can say no to their doctor and don't want ongoing treatment. I mean, that is one of the things we're talking about. But I was representing the end-of-life option out as one of multiple end-of-life options, with it really providing more space for conversation. And it was very interesting to me that with nurses, with hospice, with medical staff, I didn't know, I had this assumption that everybody would be supportive of it. And that wasn't the case. And it was
That's
very
a very bold assumption, darling.
That's what Stephanie kind of does. That's sort of her
No, it caught me off guard how kind of, because of people's political, I learned quick because I'm not, I want everybody to like me and be on the same side. So if I was representing medical aid and dying, not everybody was like, some people were like, thank you so much. And others were like, ooh, I don't know what to do with it, because it was something new. It was different. It challenged their way of how they were educated, their religion, their ethics. So I understood all that, but I knew that I had to come to a place, definitely with advocacy, but also with curiosity. And I just wanted to put that out there to you, because I had to check in with myself and not assume, like we shouldn't do for a lot of things, that everybody is going to be on the same page. So that's why it's very important to be inquisitive. If you work in this space, see how people respond whenever you bring it up, because you can tell maybe it's just new to them, and you might have to educate them about terminology. You could see they might be triggered by certain words. So that is just, for me, I always try to come up from a place of curiosity, because you don't know where people are coming from. That's about death in general, but even more specifically with medical aid and dying. And I was going to hit period. Go, Jill.
Yeah. I'm like losing it again. Okay. So I just want to define this term before we go any further. And I want to define specifically what it's not.
Okay. That's our chat question too.
Okay.
Okay. Well, let's let Jill speak it out first before we play the game, because this is worthwhile. I got it. I've got it ready to go. Ready to go.
Yes. Okay. So we'll define this by exactly what it's not. It is not suicide. The act of suicide is done by somebody who's doing it because they want to die. That's the intention, to die. Okay. Someone with medical aid and dying has been given a terminal diagnosis. So whether they like it or not, they are dying. So this isn't any kind of choice. Okay. The second thing it is not euthanasia, because when I say this is a self-advocacy process, you also have to be able to pick up the cup and drink and swallow this medication, or have the physical ability to push it through a feeding tube. So you are taking it yourself. No one is putting a needle in you or force feeding you this medication because they believe it's your time, like we do with animals. So we're not putting the needle in the animal. So this is not euthanasia. This is a prescription that's available to you to have in your home if you are to experience a time of suffering and you know your days are just going to be plain suffering. And that is a possibility with disease process, different kind of dying. So just having this medication present actually palliates the fear of being caught in a pattern of suffering and just wanting to end it immediately. So you can choose, as your days go and are turning worse and worse, your suffering can stop. So what it is, it's a prescription. It's a lethal prescription. That's what it is. It is not suicide. It is not euthanasia. It's lethal medication.
So with that
Wait,
in mind,
can I add one more thing for the definition? I'm sorry, Steph, I got to do this. You know, it's important.
No,
When you have a death certificate,
Yes.
medical aid and dying is not listed as your cause of death any more than chemo is listed as your cause of death if you have cancer. Medical aid and dying is, and that matters for life insurance purposes, that matters for historical purposes, that matters for the narrative of a family. And I think that those two things, it's not euthanasia, it is not suicide, and it is not listed on a death certificate, are three important things to know that have been written in to the structure of this concept.
Definitely. So those are right. Those are in terms of what you should know about them. This is not something you can put in your advanced healthcare directive. And you can put it in there, but it's not going to be honored because you have to be able to talk to yourself at a certain period of time. The death certificate, on the death certificate, it says that your underlying cause. This is all like what in the policy, in the legality. It's so true to note that, because it's about the dignity and the underlying cause in there. So those are other two things to really be aware of. So once again, now you know the answer to chat question 2. And I can also respond to some of why we put some of those in there. And that is, In other terms to correctly reference medical aid in dying are A, death with dignity, B, assisted suicide, C, euthanasia, D, physician assisted death, physician aid in dying, or E, other. Now, one of the reasons that well, you can read through it, Megan, and then I'll have.
Well, I mean, everybody's got the right answer.
Well,
It's
actually, it used to be known as death with dignity, and it still could be. A lot of doctors use, and just to be aware of out there, it is being known as physician assisted death and physician aid in dying, or PAD. PAD.
See, that's the kind of language that makes a physician want to back the fuck
Yeah.
away
I'm saying
because they don't want to get sued.
Other people call it that. We shouldn't.
so
It's not about the physician any more than chemo is about physician.
I'm saying it's not assisted suicide and euthanasia in the legal terminology in there. We used to call it death with dignity. The reason why it was shifted was because everybody should have a dignified death with however they want it. That's traditionally how it was used. You can still use it now. But what we do know is that it's not assisted suicide and euthanasia, as well as even the American Association of Suicidology recognizes the practice of physician aid, medical aid in dying as distinct from the behavior that's been traditionally and ordinarily described as suicide.
Well, so is D the right answer then, Steph?
It
No,
can,
A
I don't
is
think it
probably
is.
the best answer.
it's A.
We should call it medical
A
aid in
and B.
dying. We should call it medical aid in dying.
It is, but I'm just saying what we do know is that it's not assisted suicide and euthanasia.
Mhm.
You call it medical aid in dying. Some people call it the End of Life Option Act. It was, like I said, it was originally death with dignity. We're, in terms of movement into neutrality and how other organizations are moving forward, and in our systematic way, we're going with medical aid in dying. Some people come to say, oh, are you talking about assisted suicide? And then I have to refrain them because that's what it used to be called. And I say, now it's not, because the people that are going through this process are not suicidal. They know they're not suicidal, but they're dying and they just don't want to prolong their process. They're dying. They don't want to prolong their death.
There are some messy waters though, in that there are people who are both terminally ill and suicidal. And that's an extended conversation, but I'm
Also,
aware.
If we want to call it physician-assisted suicide, let's call it physicians-assisted suicide, because there have to be two of them. They can't be employed by the same person or have any sort of same dealings. I mean, if we're going to call it that, let's get specific. It's physicians.
Yeah, but I mean, look, bottom line, it's a medication.
Yeah. Jill, do you want to talk a little bit about the medication and kind of what your experiences are with that and what it looks like to take it?
Sure. So at least I know here in California, so I suspect other states are suffering from this as well, but we transitioned, basically the medication used to be the use of secobarbital or phenobarbital, maybe mixed with morphine, but the secobarbital, the Seconal, was a pretty tried and true method. That was when you were undoing the capsules. It would take 45 minutes, and mixing it into a drinkable solution. So the pharmaceutical company that makes Seconal does not make as much anymore. It also was very expensive. I'd seen the prices at $3,000 to $6,000, and they could be higher. Or even lower. I don't know how that happens. So I don't see that prescription much anymore unless somebody has had it for a number of years, because they typically don't prescribe that one anymore. What we have now, so that would have been a pure one medication. What we have now is a compound of 3 to 4 medications. So they manage, and I'm not gonna break it apart completely, but it's morphine heavy. It's 15 grams of morphine. So it's a kick in the fucking ass. I've never seen it not work. There's also digoxin, which is a heart component. I've never seen anyone last longer than an hour. I had a client go exactly 60 minutes, and that was like also his personality, just to like push it to that very moment, where I would think about having hospice like add additional morphine, because the heart component is going to kick in and overdose you eventually. So you'll die of a cardiac death no matter what, but we don't want it to come to that point. We want the very drifty, it's like going off into euthanasia. You drink it and like a few minutes later, you're totally unconscious. And then it's just a matter of time before your breathing slows down. So it's a very peaceful process. When I work with families, it's like going up the roller coaster, because they don't know what's going to happen when you're putting that compound together. And it's like, oh, fuck, we're doing this. We're about to like, someone's about to die right in front of our eyes. Like, and it's our loved one. Like, the psychology behind it is kind of crazy. But then after the person takes it and goes unconscious, you see the family like hold, cradle, speak to this person. And it's one of the best things I've ever been blessed to witness. I think can be seriously beautiful. So sorry, I probably talked a little more than I should have, but I believe in this.
No, I mean, one of the other things is Medi-Cal does cover prescription in the process.
Yes,
Now,
Medi-Cal does.
Medi-Cal or Medicaid in certain states. So once again, being an advocate for all components of having to teach and educate and be aware is important.
Yeah.
But that's
Medicare won't cover it. I've seen the medication as like, it's going to be expensive, but I've seen it get as low as like $300.
Yeah.
We'll talk more about specific costs. I'll share exact dollar figures when we talk later.
Yeah.
Okay.
When I share in a minute.
Yeah.
The cost varies.
Yeah.
Yeah. And so there's prescriptions.
I found it very affordable. For my family, it was absolutely within the realm of possibility.
Right. And I think with different families and where they are in terms of they have to go out of pocket to find a different doctor, not their healthcare system, if they have to drive far distances, like with every individual, circumstances are different, but the advocacy, the education, connecting to other people and community for physical, emotional support is so important. And being on hospice, especially because most people who take advantage of this or want to participate in this law are at home. Usually within healthcare systems or hospital environments, it's very hard to get prescription. So it's very nuanced. And so the idea of a lot of people that want this would prefer it to be at home.
And you 100% will not get this prescription from a Catholic healthcare system. Yes. And that also means people that have a Catholic, like Dignity Health has a Catholic ethics code. So any hospital under Dignity Health, like you're not going to get anyone to prescribe. So be aware that you might have to ditch your healthcare system to get access to this.
And that's one of the things that as we're working on education, supporting patients and families in our work, and some other organizations, Compassionate Choices is also collaborating with other organizations because there's so many healthcare systems that are collaborating, and they stopped UCSF with Dignity or another healthcare system up in Northern California because of wanting to make sure people have access to this. So there's also a lawsuit after the California law passed. And then there's this 10-year sunset clause. So the idea of people having good experiences, and there's been no abuse from people participating in this, is so important. And so I think we're going to go to the last chat question here. And then I think we're just going to open it up. Because there's a lot of information, as you can hear just among us. We all have different perspectives and experiences, which are all valid, and how we talk about it and how we share out. So the question Megan put up here was, can you know, I need to spell check sometimes. Megan did not write that, I did.
I'm supposed to do that. Amber would have caught that one.
Megan is so good at this. Do you know anyone that has gone through the medical aid and dying process? And that's going through the process. And I didn't say just taking the prescription, because it's really, it can go within that spectrum. So if A, yes, B, no, or in the process. If any of you have experienced, known anybody. Megan and Jill will share, I can share. And then if you guys have any questions, we have the next kind of 15-20 minutes just to kind of open up and to hear stories and hold space. And
if you don't know somebody, you will.
Yeah.
You will.
Yeah.
Yeah.
So we see a lot of B. So many people do not know anybody or in the process. So thank you for sharing that. Megan has a very personal experience that she was open to sharing with us today about her
I'm
experience.
excited to share it. Honestly, like,
okay.
Welcoming my dad out of the world was as exciting as welcoming my kids into the world in a lot of ways. By the way, I'm Irish. I will cry. You can feel uncomfortable with that. I'm okay with it. Helping my dad, who has been talking about medical aid and dying forever, achieve what he had always wanted to achieve was a gift. And I want to start with that. And I also want to say that my dad went through the process of medical aid and dying and never actually filled the prescription. But because the process existed, and because he was able to have control over his body and his future and his path and his exit, he was able to face some pretty heavy, scary shit with like a lot of confidence because he had some autonomy. So my dad was diagnosed with cancer last year in June. And thankfully, I'd already been working with Jill for a number of months to help her format a document. That's where our friendship started. And I was able to call Jill in right away. And one of the things that she mentioned earlier is the time frame. And I kind of, my goal is to share with you guys the numbers because I think that that's stuff that I have locked in my brain. And I think it might help articulate what the process of this is like. So Jill mentioned at the beginning how one of the biggest barriers to access this option, and I don't want to call it a medication. I don't want to call it a prescription. It's an option. My body, my choice. And I have accessed that personally. This is somebody else's body and their choice, and being able to back them up on that on a real level. And my dad was like a long-term Planned Parenthood contributor. He was the treasurer of our local health clinic. He was like a big pro physical autonomy person. So to be able to honor that is part of why it's so exciting to me to be able to share this story, like joyful. So as soon as my dad got his prescription, I knew who to call because it was Jill and I had her phone number and I was able to call her on every level, right? And she came up and I knew that that's what Bob, who's my dad, who I love, and I call him Bob because everybody knows him. And you will know Bob at the end of this story. You already know Bob. I was able to call her up and say, okay, Bob's ready to do this. I know he's ready to do this. We've had the talk for forever. I know that he wants to run this. And so Jill came to the house. We had a little bit of a family talk. She said very casually, Megan, it's time for you to step away. I'm going to talk to your dad. She had a conversation with my dad and gave him the down low. And that day before she pulled away, that was July 2nd and of 2019. And before she pulled away from the curb, she called her contact because she knew the guy in California that would be able to access what option my family needed. And she made a call to the guy and we talked to him on July 3rd and he had his official first conversation with my dad on July 4th. So we go from the June 23rd diagnosis, hospice that night. We didn't even go into the doctor's office to get the diagnosis. there was no need to. We knew what we needed, which was the good drugs. We went on vacation the next day. We had Jill a matter of days later. We're in contact with the doctor, number one. We have the the video conference. Part of the video conference is that my dad actually had to pick up the computer and show the whole room to show that there was nobody else in there. And I was sitting there. And so the doctor said, I need your daughter to get up and close the doors of this room and leave. And then, hi, George, and then I need to say it again. And he needed to go through the whole thing to make sure that there was no pressure. And then I think it was a full 2 weeks later. And if you've ever worked with somebody who's on like a stage 4 cancer diagnosis and taking daily amounts of morphine and Ativan, 14 days is a long time. And 14 days later, we had to have a conversation on video with another doctor who again was incredibly accommodating and wonderful. Then I believe it's a 30-day process from your first physical conversation until the prescription can be written. And 3 things need to happen. You need to talk to 2 doctors. At least one of them needs to be an in-person physical, in the same physical space conversation. And then you have to meet all the eligibility requirements. So on July 23rd, I believe it was, Dr. Bob, not my dad, Dr. Bob got in his car in Del Mar and drove to Ventura, which is about an hour and a half north of Los Angeles Airport. So I don't know that he would have done that had it not been for Jill's recommendation. I don't know, he told us what the price was, and I said, that's it? It was $6,000 for everything that I'm telling you now. All these multiple video conferences, 2 different doctors, Dr. Bob to drive all the way up here. If we had visited him, the full price would have been $5,000. My family has a saying, if money can solve it, it's not a problem. We can get money. Real problems can't be solved with money. So Dr. Bob got the $6,000, and on July 23rd, my dad received his prescription. So it must have been July 31st. Dr. Bob must have waited until the 30-day minimum to actually officially write the prescription. At that point, my family transferred over to a specific pharmacy, which was also based in San Diego, and I was provided the name of a pharmacist, and Dana and I got on the phone. And at that point, now we're paid up with Dr. Bob, we're done there, we've got a prescription, and now we start a second process, and that is obtaining the medication. And by the time we got this prescription, my dad was pretty far along. And the idea of him even consuming 4 ounces, much less, he wouldn't have been able to consume 4 ounces at once. He wouldn't have been able to, it was less likely to work. But the process itself had brought us all the way to this place. We had had something to do. We had had something to work on. There had been a treatment plan in place, and we had had a shepherd, and it was Jill. And we ended up, the pharmacy was amazing. They took a hold on our credit card for the $775 of the prescription drugs themselves. We were going to have to pay another $300 to have them couriered in a car from Del Mar, San Diego area up to Ventura. Again, this is the cost of doing business. Okay, it costs $300. It costs $300 when you're in that place. And what the pharmacy did was they put the hold on our card and held it all at the pharmacy. And so we always had it in place, and we didn't actually, people always say, did your dad use it? Or did he use it? I'm like, absolutely. He used it for every single thing it was intended to be, which is an option. And did he have it administered to him? Did he self-administer it at the time where we had an idea about people No, he didn't. But did he use it? Yes. Absolutely. And had I not had a personal connection and somebody who said, not only do I hear what you're asking and know what you need, I'm getting in the car, driving to your house, sending you out of the room, talking to your dad, making the connection, and facilitating the entire process as an emotional companion. This option isn't available to everyone. And over the last 2 weeks, I'm gonna say it, as we have addressed a lot of fucking inequalities in this world, I am realizing how just knowing the right person to call is a way that I had I had the ability to make a phase of life easier for somebody that I care for. And that knowledge is all we need. That knowledge is what Jill can share. And it's how we can bring whole communities forward as far as having options and power. And we had the most kick-ass party long after I thought my dad would be able to drink 4 ounces of medication. I'll tell you what, he drank gallons of fucking beer and ate buckets of clam chowder. And it was because we had that on hand. And so, Steph, one thing I want to say is a bit of a cheers to you. I had no idea that you guys expected this to be a 5-year process. And if it had been a 5-year process, it wouldn't have been available for my dad. And like what you did helped me, I birthed a human out of this world. And it was a lot less gory than bringing the other 2 in. So cheers to you. Thank you for whatever sausage you had to make there. I love you all.
Really, thank you so much for sharing your experience and the details. I mean, it's so important to hear those, like, the timing and the drive and the location and the friendship and the movement and who do you have and who do you don't. With passing the law, it was really a lot of things aligned. We had co-authors of the law were brilliant and amazing. One was a hospice social worker. So she really got, like, Assemblymember Eggman, if you ever want to hear something powerful, I need to send you her YouTube about why this law needs to go through. Like, it was really great. And we had Brittany Menard, who had to move out of state and not have the support of her family and friends as she was going through it. And that's why her and her husband, Dan Diaz, he's still advocating across the United States on this.
He's gonna be at our Reimagine event next Monday.
Right.
Yeah, if you want to hear Dan Diaz's story. But Megan, stories are how laws get passed.
Yes, I mean, definitely.
So it's a cyclical,
it wasn't.
For those of you who don't know Steph, she's incredibly tenacious, and it doesn't surprise me that Steph compacted 5 years into one.
It wasn't, no. Seriously. Yeah, no.
I know it's a lot of people, but your energy was definitely there.
They were afraid.
So here we all are. Some of you have experience with it. It's a unique, beautiful experience, as Jill articulated. Same with Megan. We have some time for some questions. Do you have some comments or questions or themes that you want to share that you're curious about? See, I use the word curious about. How do you guys feel? Please add some questions, some comments.
And, we're aware that there are places in the world that have less regulation around this. That's interesting to you.
Yeah, some have different regulations. Like we said, it's changed in Oregon. It's one thing I find very interesting to work on advocacy on a law and another thing for implementation. And I prefer the education side than the policy side of things. It's just more of my comfort because I want to be and hold space for families. And there's other organizations, there's us as individuals, there's other organizations that provide free information and support in general. But in terms of really getting that connection of hand-holding and advocacy, there are individuals like Jill and I and that are out here to hold things like that. And there's Megan. So any other, what is rest? So Callisto asks, what does less regulation look like? It's the hours. We're looking at that moving from the 15-day requirement to 48 hours. It's interesting that the California law was the regulation was a little more restrictive than we would have liked. You know, the idea of having to report on this information, having a mental health. So one of the things that Aishan brought up was if you feel this person has a mental health issue or consideration, then you have to send them for a psych assessment. Now, that usually doesn't happen because people have already gone through the process, but there's certain healthcare systems that require a psych eval, not to work with a social worker talking about end of life options. So it's really about culture, you know, like we talk about death in general, but around end of life, what the culture is around it. In Hawaii, they made it a requirement to have a psych eval. So in a place like Hawaii, when there's no access, that just makes it more challenging. And I know they're looking to change that. So there are, I think the amount of days, the going to 40 hours we'll be looking at as one of the things to.
And there's a check there. The check is like, if your doctor evaluates that you're not going to live, like, so, you know, you need a doctor that's used to like looking at death and can make the assessment, because this is where they trip up, as they say they won't evaluate like how much actual time. So you have to get pretty specific. I don't think you're going to live past the next 3 days, next week, so I'm going to just go ahead and give it to you.
Yeah. So with Aishan also brought up the idea of the prescription and what does it look like in other countries. Just to let you know, in Canada, you know, medical aid in dying is an option in Canada, and it looks a little differently there. Doctors are allowed to administer medication there, and a lot of people take that option. Here, self-administration is orally, through, or feeding tube. It comes in different compounds or formulations. Sometimes you have to take an anti-nausea, anti-anxiety medication.
Always you have to.
Yeah.
That's
Always.
like the first part of
the
it.
anti-anxiety.
Can we say one thing though?
You can
Hospice has been doing this for decades. As
They
long
have
as
their
hospice
ways.
has been here, if hospice will send you the angel nurse that will show you when it's time. Like one thing I want to do is I want to reduce any anxiety about this not currently being available. And I just want to say that, like, when my dad got close to dying, we didn't tell hospice about the medical aid in dying thing. They would have gotten butthurt about it, whatever. When my dad got close to dying, they sent out the angel nurse, and she was this amazing AIDS nurse from San Francisco from the 80s who sat down, the only nurse that ever sat down on the couch with me alone and was like, all right, this is what you do. This is how it works. This is what's going to happen. This is what you need to give him beforehand. You need to give him anti-nausea. You need to give him anti-anxiety. Like, you need to use the liquid morphine. So as we talk about medical aid in dying and we talk about getting it on the books legally, we need to know that the human beings who guide this process are already fucking doing it and
Right.
succeeding all the time. And that's part of the reason why I always want to share Bob's story. And before we get to 6 o'clock and we're there right now, I do want to say, this is the first time I've ever publicly shared Bob's story with people who I don't like personally know. And it was great. And I want to do it again. And I do believe what Jill said. Stories pass bills. And when old white men start believing my body, my choice, I don't want to shit my pants on the floor and have my adult daughter change my diaper. I'd like to just opt the fuck out by then. And I'd like to believe that I have the right to do so. When we can get those guys who are actually sitting and voting to understand this, then things are going to get changed.
Yeah, when people have their own experience and their own stories, that's
and I'll give them Bob's.
Yeah.
And Bob's pretty approachable.
And another big change, and look, it's all about the person. It's about us and personal stories and us going through it. when there's societal and changes in organization, it makes a difference. Yesterday also, and I didn't realize this, was an anniversary of American Medical Association changing their policy to adopt that affirm that physicians can provide medical aid in dying according to the dictates of their conscience without violating their professional obligations. Doctors were doing that before, but now they're that fear, that tension, or whatever, that acknowledgement. This was years in the making, years behind the scenes of individuals like this in a medical arena trying to shift this language. We are there now. It's been a year since that language has changed. Culture is changing, and that's for us having the experiences and sharing our stories. Thank you so much, Megan. We honor Bob. I know you and your family have so many sayings. What's one from Bob that you can end us with? Like, I'm sorry, I know they're always so fluid now that I asked you.
God.
You're like, I don't know.
Bobisms.
Yeah, Bob
He said, what did he say? Walk softly and carry a big stick.
Nice.
It's a Theodore Roosevelt, but we are Irish. We adopt from anywhere. We don't.
Thank you. Thank you so much for being here. Another cheers. You guys were great listeners today, but we're here, and if you have any questions, as you can see, we're passionate. We all have different experiences and knowledge about this, about death and dying, and medical aid in dying as an end of life option. And next week we're talking movies, so come join us.
Great.
We're gonna take a little break
After
from
my
all
heart.
the heaviness and talk about movies. And honestly, you guys know I don't cry much, but when I start thinking about my favorite scene in a movie, I might be like, oh. We'll see.
Callisto, that's part of what I was supposed to talk to you about before today is death in movies. We're gonna get in touch.
Be well, everybody, and thank you so much for joining us.
Love y'all.
Cheers.
All right, I'm gonna sign off.